the technology we're using for that is infrared light. And so it's a little different from like Bluetooth or something that could kind of transport through walls, meaning that if you're in an exam room, what you end up seeing is a light that pulses and shows just inside that exam room. And so it does a really good job not communicating out. So yeah, for that question, they are, on a wall, but because it's line of sight, as long as you're, in an exam room, it really does a really good job capturing that. We've done a lot of testing with other technologies, and infrared has been the most effective in an exam room environment. The short answer is the median is lower than that. So median is closer to 2 across community health. We do have health centers where they're up 2.6, and we actually have a couple that are north of 3 on average. But what we see just in the aggregate in community health is that it's around 2 on the median.
Alan, just a question for me. Do you notice an improvement when you engage a client in that metric?
Yeah, it's a great question. I would say we have clients where they're prioritizing that and they're saying, yes, we need to improve that number. We also have clients where they're saying, hey, productivity is pretty good, or we just don't feel like we can ask people to improve that number. I'd say there's 2 ways to do that. One is, let's just say there's a bell curve of your providers and their productivity. Typically what we see is you can either try to move the median on the bell curve. You usually do that with your templating, right? And you say, okay, previously we were doing really 2.5 encounters per hour. We were doing 3.5 encounters per hour. We're going to move that to 4. We're going to move it up a half encounter. So that's kind of moving the whole bell curve. The other thing that we do see, probably more common now, is we see organizations where they're saying, we have providers that are on the left end of that bell curve that are performing below our expectation and our median, and we need to work on how do we get those providers up consistent with the others. We find that is often lower hanging fruit than trying to kind of move the whole mass. Usually organizations, whatever that expectation that has been set is often a little more difficult, and not necessarily a technology thing. It's more of operations and clinicians coming together and saying, hey, this is where we feel that should be. Mark, I'd be interested in just your take on that, because I think we're all very aware that no money, no mission, right? And ultimately, part of the question is how many patients' lives are you able to touch? So I'm just curious how you see that play out in your data, and kind of how you maybe prioritize striking a balance there.
Yeah, I think it's not always necessarily about people working harder. It's more about working smarter. And I think if you're using resources in an optimal manner and you're eliminating wasted motion, then you can achieve both goals. You can improve staff. By the way, that's another thing we measure is employee engagement. And they all tend to move together. You can improve employee engagement, customer satisfaction, financial results. There's a ton of research that shows all 3 of those do move together quite a bit in healthcare. So it's not about making people work harder necessarily. It's just about better communication, better coordination, better utilization of time and resources. And those things combined will deliver a better patient experience as well.
Yeah. And I think one of the elements to what you just said, Mark, is if you really go and sit in a nurse station in 2024 in a community health center, what you're going to observe is a whole lot of time spent on things that just don't add value for any patient, right? Mm-hmm. And it's things like the simple one that I'm always, it's like, how long does it take before I hear the question, where is blank? Where is my provider? Where is, this person? And for us, obviously, that's, part of what our system is optimized for. What we found is there's just so much time we spend on these tasks that, in 2024, I think artificial intelligence has a huge role to play, but there's also some just technological and some leadership management problems where we just need to get into the weeds a little bit, look at these challenges and say, okay, that right there is waste. I'm calling it waste because no one's getting value out of the time that we're spending chasing down that, piece of equipment, or the time that we're spending trying to, 7 clicks in to try to get to the patient's blood pressure, right? And so I think if we really just take a surgical view, a systematic view of those things, what we often find is that there's so much waste. And the way it's manifest is that our average provider that we see in our data is only spending 32 minutes an hour with patients, meaning 28 minutes per hour is doing things that probably are not really requisite of their license. Obviously, charting is important. Obviously, following up to emails and kind of working through their bucket, that's important. But really, I think providers want to spend time face-to-face with patients, and they're paid to diagnose and to provide treatments. And I think we expect a lot of administrative work that hopefully we can optimize around that.
I'll never forget years ago seeing an emergency department provider pushing patients to radiology down the hall on a stretcher because there were no transporters. So hospitals paying a lot of money to that provider to push a patient down the hallway. Not good resource. Yeah.
Yeah. No, we were on a call today actually with the health center where their MA to provider ratio is 0.25. They have one medical assistant rooming patients for 4 providers. It just doesn't work. You end up with providers doing a lot of things that are way below license. So, cool. Go ahead, Amanda.
Yeah, we've got a couple more. So someone said, do you have any data on patient satisfaction correlated with self-rooming versus MA escorted rooming?
Interesting. Mark, is has that come up at all for you? That's something we're just starting to kind of tinker with. So I'll share some of the anecdotes we've heard, but is self-rooming ever? Yeah.
No, but that's the sort of thing. We develop a lot of content for our clients. So we have benchmark questions that are standardized and benchmarked, but every client also has their own custom, unique learning objectives, if you would. And that's the kind of question we could incorporate into a patient survey if it were needed.
Yeah. Just for reference, we are doing this with a customer in Michigan. And essentially the patients come down kind of a separate corridor. The tablet on that side flashes green on the sides and it says like, welcome Mark to your exam room. And that's they had seen that in some of their data, which is, probably more rudimentary in terms of how they're capturing it, but they are capturing some data. And so what we've noticed on the data side, kind of our operational data, is that the patient lobby time goes down to effectively nil. And then that alone time goes up about half the time of that lobby time. So overall, their visit gets shorter. There is a little bit longer, alone time in the room, but overall it is more efficient. But the big thing is that patients perceive it as a very favorable experience. They really just appreciate kind of that concierge, like you get to your hotel and they're, yeah, hey, we're expecting you. You're going to be in 221. It takes 30 seconds. And then, kind of the system all kicks off from there. So I think that's probably some of the root of that question.
All right. Thank you, guys. Okay. Next question says, for a new health center build, have you ever been closely involved with design optimization for SyncTimes?
Yeah. So I think that's probably a question for me. And the short answer is yes, we've definitely been involved with kind of design optimization and how we're using SyncTimes in a new facility. We also have short answer is yes, we've definitely been involved with kind of design optimization and how we're using SyncTimes in a new facility. We also have some partners that we work with that I think Boulder Associates is a build design firm that I think does a really good job with that. And so obviously not an architect, but very familiar with healthcare workflows and love to kind of help dig in on that front and maybe share some thoughts on that. So. Just some quick thoughts on that. It depends a little bit on your state. And just in that some states require like a certified medical assistant for certain things. Some states actually require like an RN to administer, to do some orders, some labs. So there is some dependency there on your state, your regulatory environment. But ultimately what we see is that if you have more support staff per provider, a couple of things happen. First off, your patients are going to have a little bit lower weight, so that does happen. However, it's at the cost of there's only so much time an MA is spending with a patient per hour. So if it's truly a 1-to-1 ratio and your patients, you have 2.5 patients per hour and your MA is spending 5 minutes with those patients, we're only talking about 12.5 minutes per hour that medical assistant is face-to-face with patients. And so what that means is if you do 2, that time is going to cut in half. Each MA is only spending 6 minutes per hour with patients, and then 54 minutes doing something else. So I think the expectation, and kind of how you manage that obviously depends on regulatory environment, but then also you just want to think through what are we expecting them to do in addition to just rooming patients and just working with patients. If you're just expecting them to do intake and to draw labs, I think the short answer is you can do that on a pretty slim ratio. However, if there's kind of a higher bar, if there's other things that are being expected, I think the way I would approach that is really measuring what are those other things. And then if we add, in addition, what does that take off of our provider's plate? One other thought there is that we have health centers where they'll just experiment with those things. So they'll take a high producing provider. They have all this data in SyncTimes of like, what is that provider doing with their time? What's the productivity? How long are patients alone, et cetera? And then they'll add that second medical assistant, and then they'll just see, hey, what changed? And obviously they'll add quantitative or they'll add qualitative experiential data talking to a provider. And part of the goal is how do you kind of quantify that ROI on really doubling your staffing ratio there. So